Welcome back to the TRT and Hormone Optimization YouTube channel. And back with us as a guest is Ryan Root. Welcome back, Ryan.
Hey, how are you, Stephen? Thank you. Thank you very much. Thank you again for all of the education that you give everybody. This channel is great. It really helps a lot of people, and we all appreciate what you do.
It's my pleasure, and it's nice to have you back with us. So you came across a study, a very recent one in 2024, just published, and it's about testosterone and the risk of clotting. So I'll put it up on the screen, and you can share your knowledge about it.
Okay. Yeah, so this really helps put into context a lot of what we've been learning over the years. So let me actually put this in the context and start from the beginning. I want to do this chronologically so we can kind of understand. Back about the last study was about 10 years ago. And before that, there was a total of about 4 studies that came out that indicated testosterone increased the risk for venous thromboembolism, which is blood clotting, right? It wasn't deeply understood like what was causing this risk. All they said is that we give people testosterone. There's a very small 10 out of 10,000 increased risk for blood clotting, and that's all that was said. This is all the information that was given. Now 2 of these studies found that after 6 months, the risk seemed to normalize back to the 0 increased risk. So after 6 months, the risk was back down to 0. That was never explained. 2 of these studies found that. Now, at the same time, there was 3 other studies that found no global increased risk, right? And now, since then, there's been multiple more contemporary studies that have found no increased risk of VTE or venous thromboembolism from testosterone. So this study is actually going to begin to elucidate exactly why there was an apparent increased risk from 4 of these studies back a decade and more ago. And we're going to elucidate exactly what's going on here. Okay, so now we'll just start with the study. Okay, so we'll start with the results here. So hypogonadal men displayed significantly higher endogenous thrombin potential. So thrombin is a clotting factor, one of the many clotting factors. One of the problems with the previous studies is that it was not the complex nature of clotting was not elucidated, right? So it was just all they did was have a very facile understanding. Fibrinogen is a clotting agent, is what is used in clots. So hypogonadal men displayed significantly higher endogenous thrombin potential, fibrinogen, and significantly lower antithrombin, which is something that reduces clots. Antithrombin levels both before testosterone was started and 6 months after testosterone compared to healthy controls, right? Mm-hmm. So hypogonadal men have more clotting factors and less anti-clotting factors. Yeah. Thrombin peak of hypogonadal men was significantly higher than healthy controls 6 months before testosterone, but not at 6 months after testosterone therapy. Endogenous testosterone potential and antithrombin were correlated with testosterone levels, right? So the lower the testosterone level, the increased endogenous thrombin potential, and the less antithrombin, which reduces blood clots. Okay. Mm-hmm. So the conclusion of this study, and then we'll go into the details, is hypogonadal men display procoagulant imbalance detected by increasing thrombin generation. Short-term TRT does not worsen global coagulation, suggesting that the treatment can be safely prescribed to men diagnosed with hypogonadism. Yeah. Okay, so now we're going to go into some of the details of exactly what's going on here. We're going to start to elucidate why there was kind of some misconception of increased clotting risk when people started TRT about 10 or more years ago. Also, what's important to understand here is the current medical community's understanding of clotting, right? It's pretty facile. All they understand for all that they're trained to look for is when your hemoglobin hematocrit goes to a certain level, or your platelets go to a certain level, that's what is going to signal a risk for clots. And they don't understand all of the clotting factors that go into this and the complexity of it. So in an older population, what we have indicated here is that low testosterone is increasing clotting factors, which is going to make our hemoglobin hematocrit is going to increase and increase the risk of clotting. So when your primary care provider sees high hemoglobin, high hematocrit, they tend to panic and say you're going to have a stroke, right? I hear it all the time. Patients come to me. My primary care told me that I'm going to have a stroke. My hemoglobin hematocrit is high. We know this isn't true. This is going to elucidate exactly why it's not true. Now, so another thing to understand is that in the older population, we see the risk of blood clots increase, the risk of venous thromboembolism increase. Older people are on warfarin. We put them on blood thinners. Warfarin, what's the other one? There's another one, Coumadin. Warfarin, Coumadin, blood thinners, right, to prevent clots. Again, this is going to elucidate why. So, in fact, both testosterone and its 5-alpha reduced derivative dihydrotestosterone exert an inhibitory effect on primary hemostasis by preventing adenosine diphosphate mediated platelet aggregation. This is also going to be true for the rest of the androgens. This seems to be a function of androgen. I did a deep dive on stanozolol earlier, and stanozolol also has this effect where it reduces clotting factors. DHT does this, testosterone does it, and I'm extrapolating to say that all androgens will do this, and we're going to see why here pretty soon. Moreover, testosterone has an inhibitory effect on coagulation and promotes fibrinolysis. Fibrinolysis is the breakdown of existing clots. So this is actually pretty big. So this means that not only is testosterone reducing clotting factors, if you have a clot, it will begin breaking it down. So this breaks down existing clots. Yeah. Consistently, low testosterone levels have been correlated with increased platelet activity and procoagulant profile. Current evidence, however, has failed to provide, that part's not actually important. Okay, so interestingly, studies by Martinez et al. And Walker et al. Showed this as an association reached a peak within 6 months since the start of treatment. This is the two studies that I said indicated that after 6 months, the risks seemed to disappear, right? Nevertheless, 3 meta-analysis randomized controlled trials did not find increased risk of venous thromboembolism as associated with TRT compared to placebo. This was the older studies that some of them showed that there was an increased risk. And again, that risk was very small. Some of them showed that there was no increased risk. We're starting to elucidate why there's an increased risk. Okay, so right here, hypogonadal men display a procoagulant imbalance compared to age-matched healthy controls, right? So healthy controls are people with middle to upper quartile testosterone levels. Cavusi et al. Reported an increased risk of deep vein thrombosis only in those hypogonadal patients diagnosed on the basis of Endocrine Society guidelines, receiving TRT and presenting their potential etiologies for deep venous thrombosis. After exclusion of these cases, the overall incidence of thrombosis was similar to the general population. Okay, so what this is saying that the studies that were done, the two that found, or some of the studies that found that there was an increased risk, they used participants in the study that had other reasons or etiologies for thromboembolism, right? So they had other reasons why they would have a risk, whether it be like an injury or just an existing condition, factor V, genetic mutation in factor V clotting agents. Like they had some other reason why they would have blood clot. So when you exclude those patients from these old studies, then there is no increased risk, right? So that's what they're saying, that the study was just poorly performed. And those are the ones that found an increased risk. Indeed, some thrombogenesis assay parameters, that is thrombin peak and velocity index, are significantly higher in hypogonadal men compared to healthy control baseline, but no longer 6 months after TRT. So 6 months after giving TRT, people's clotting factors or procoagulation agents are normalized to the same as people with healthy testosterone ranges. This observation may suggest a trend towards the improvement of procoagulant imbalance following TRT, but a longer time may be needed to achieve normalization. The need for a longer time to attain parameter normalization has already been observed in the endocrine disorder characterized by an increased thrombotic risk. Right? So going down. Okay, low testosterone levels have been correlated with increased platelet activity and procoagulant profile. Conversely, both testosterone and dihydrotestosterone have an inhibitory effect on primary hemostasis as measured by the in vitro tests by preventing adenosine diphosphate mediated platelet aggregation. Right? This effect obtained directly by the activation of the receptor on the platelet membrane and indirectly through the anti-aggregatory effect of nitric oxide produced by the stimulation of endothelial lining cells via the androgen receptor. So this is saying that testosterone itself has a direct effect on platelets. Platelets have androgen receptors that prevent clotting. Also, the cells inside the veins have androgen receptors that, when received, they increase nitrogen oxides, which has a vasodilatory effect, which prevents clots as well. Right? So testosterone itself directly affects the coagulatory factors and reduces coagulation. Moreover, testosterone increases the expression of tissue factor pathway inhibitor and tissue plasminogen activator and reduces the secretion of plasminogen activator inhibitor, thus inhibiting the coagulation cascade and promoting fibrinolysis. So the entire coagulation cascade is inhibited by testosterone, and it also promotes fibrinolysis, which is the breakdown of existing clots. Right? Okay, so this last part, I wanted to, a lot of times there's a spot up here that I just wanted to throw this in. There's a spot up here that indicated a lot of the information about the hypogonadal men and the healthy controls that they have middle to high range testosterone levels and hypogonadal men. Something of interest I just want to point out here. Look at the BMI that they had for these two. So the healthy controls had most of their cohort was in a BMI range of 18.5 to 24, while only one hypogonadal man was in that cohort. And the hypogonadal, the most in that cohort, in fact, just about all of them were in a range of BMI of 25 all the way up to greater than 40, right? So this means this is more evidence that we have of that low testosterone causes metabolic disorders and causes this obesity. Most of the people were obese who were in this hypogonadal class. And, we've been taught the antiquated notions prior were that your testosterone level could be low because you're overweight, because you're obese, right? Yeah. We now know that it's actually low testosterone causes us to be obese. It's exactly the opposite. And we see that time and time again. Low testosterone causes metabolic disorders and people are overweight and unhealthy. That was just kind of an interesting side. But but obese people do seem to have a little bit higher risk of clotting, right? And so in order to dispel the notion that possibly these obese people, they're higher risk because they're obese, right? And that's what this does right here. Overweight and obese are considered as comorbidities commonly associated with male hypogonadism and have a higher prevalence in this population. On the other hand, components of metabolic syndrome, including visceral adipose tissue, can negatively affect thromboembolic risk. Nevertheless, it has been shown that male hypogonadism has a negative effect on hemostasis per se, independently of the association with metabolic syndrome. So they're saying that, the increased coagulatory risk of hypogonadism is independent of them being overweight. Okay. Okay. So what does this all mean? So what this means is that there was the study from a decade or more ago. The studies from a decade or more ago showed that we gave people testosterone. They seem to have a very small increased risk. In some of the studies showed no risk. But what was happening is, now that we now see this, before I read the study, I knew that testosterone did not increase the risk of clotting, but I didn't know exactly why. And I didn't understand that testosterone actually reduces the risk of clotting.
Yeah.
So when we gave, the problem was that we let people go hypogonadal in the first place, right? We let people go hypogonadal, their clotting risk came up. Then we gave them testosterone, which we know increases hematocrit and hemoglobin, right? So when we increase their clotting risk and then increase their hemoglobin and hematocrit, you can see where there might be an issue there, right? And it takes about 6 months, as we've seen, for all of the clotting risk, the clotting factors, the procoagulants to normalize. So in that 6 months, some of the studies were saying there is a slight increased risk. Other studies were saying that there is no global increased risk, but you can see where there could be an issue. The problem is letting people go hypogonadal in the first place.
Yeah.
So you can be proactive and make sure you never go hypogonadal, get on testosterone well before you're at that hypogonadal stage, and then there's no increased risk of blood clots. The human body is a symphony. Like, we evolved to be this symphony, and you can see it, right? Like, when we give testosterone, it increases our red blood cells, which increases hemoglobin. Hemoglobin is what binds oxygen. Oxygen is repletes our body's ATP. ATP is our body's currency for energy, right? So increased red blood cells means more oxygen equals energy, right? And when we increase our red blood cells with testosterone, it increases the production of EPO, which increases red blood cells. That's a good thing. And our body also reduces the risk of clotting, because the testosterone has direct effects on all the procoagulation and inhibits coagulation. It's just a beautiful symphony, the way this all works.
Yeah.
So that's again, all these studies from a decade or more took a very facile look. They just said, we give people testosterone. It appears that there's a very small increased risk. Therefore, testosterone increases risk. And again, your primary care provider were taught that the older population, their increased risk for clotting. So if their hemoglobin and hematocrit goes above the range, that's dangerous. It could mean that they clot, without understanding the deeper complexities of clotting. So we now know that the older population that are having clotting issues is because their testosterone is low. If we gave them testosterone before they ever went hypogonadal, they wouldn't have this clotting risk. And you can see it throughout, like all the nursing homes, throughout all these medical issues. You can see like all the decay and all the problems that low testosterone is causing, like the degeneration and the decay of everybody as they age is largely due to low hormones, right?
Yeah, sure. It's very surprising, but it's very nice to have explained by you, because we all knew this was the fact, but we didn't understand why. So,
Right.
very nice study. Thank you for explaining it.
Yeah, absolutely. It did elucidate it for me as well. So it makes it easier to explain, and makes it understand why having testosterone not only does it not increase the risk, but when your hemoglobin and hematocrit start to increase a little bit, it's a good thing until it gets to a certain point, right? At a certain point, we're not worried about increased risk of clots, but we're worried about increased risk of hypertension, symptoms of hypertension, right? But if we're just above the range, 51, 52, 53, 54%, we're not worried, right? Because that's actually a decent range to be in. And your body's taking care of, the testosterone is taking care of all the clotting factors.
Exactly. So we're reassured now. There's nothing to worry about. Just for the people that are hypogonadal and starting TRT in the first 6 months, maybe.
Yeah, Right. And that, a lot of the studies also showed that there still was no global increased risk, even in that 6 months.
Mhm.
But again, some of the studies that showed that they were poorly run studies. They had patients who already had other reasons, other etiologies for clotting. So there's other reasons why they would clot.
Yeah.
So it's probably still not a risk, even if you're hypogonadal. But again, you're right. The key here is never let yourself go hypogonadal. Treat yourself well before you're at that range. And as we've seen, the most consistent benefits from testosterone are found just above the normal range, the normal testosterone range. So you want to keep yourself there anyways.
Yeah. Very clearly explained. Thank you so much, Brian.
Yeah, absolutely. Thank you, Dr. Devos.
Okay, thanks for coming back on the channel, and talk to you next time.
Okay.